Good afternoon, everybody. My name is Dr. Manjiri Bakre, founder and CEO of OncoStem Diagnostics, talking to you all today. Let me start by sharing my screen. Today, I'm going to talk to you about global validation of CanAssist Breast, a prognostic test for hormone receptor positive, HER2 negative, early stage breast cancer patients. The agenda of my talk is as follows. I will first explain recurrence pattern in breast cancer patients, then go over the importance of prognostic tests, and then talk about CanAssist Breast in particular, which is a made in Asia, the only made in Asia prognostic test, and then compare CanAssist Breast with other gold standard tests like Oncotype, MammaPrint, and commonly used tools such as Luminal AV and IHC4, and explain the usefulness of risk stratification with respect to treatment planning, and how is CanAssist Breast helping patients today in saving chemotherapy. So let me start with treatment patterns for different breast cancer subtypes. So primarily to make matters a little simple, what I'm going to do today is the breast cancer is primarily divided into triple negative breast cancer patients and HER2 positive, ER positive, HER2 negative early stage breast cancer patients. So if you look at these two main subtypes, the absolute risk of distant recurrence differs for each of them. Triple negatives have a higher absolute risk of distant recurrence, 50 to 60%, whereas hormone receptor positive EBCs have 10 to 15%. And what is the benefit of giving chemotherapy to these patients? The risk of the relative risk reduction with the chemotherapy is 30% to all patients, irrespective of which type of breast cancer they have. And the absolute benefit of chemotherapy, however, changes significantly. For triple negative, it is 15 to 20%. For hormone positive, it is 2 to 3%. Now, whenever you give chemotherapy, you need to weigh in the chemotherapy benefit along with the toxicity of chemotherapy. If you look at the toxicity rate of chemotherapy, it is about 2 to 3%, again, irrespective of the breast cancer subtype to the patients. And since in case of ER positive patients, the benefit of chemotherapy equals the toxicity rate, it does not always make sense to give every patient chemotherapy, and hence it is important to prognosticate which patients will actually benefit from the chemotherapy, thus downscaling the disease, the de-escalation of the treatment. So there is clear evidence for personalization and de-escalation of chemotherapy in hormone receptor positive, HER2 negative early stage breast cancer patients. I think a lot of work has been done in case of prognostic testing in the past, and Oncotype DX has carried out this massive big TAILOR-X trial, which showcases that not only about 4 in 100 patients actually benefit from chemotherapy in the early stage hormone receptor positive patients. And this is Oncotype DX has been included in NCCN, ESMO, NICE guidelines along with other prognostic tests as well. So prognostic tests are really important, and they have been, patients are also aware of them, and patients are factoring in quality of life into treatment choice. The importance of prognostic test was also showcased by AJCC redefining the clinical staging paradigm. Clinical staging as follows. Earlier, the clinical staging of the disease used to be entirely anatomical based, TNM based, but now they have realized the importance of prognostic tests and the risk stratification group that they bring in. So now, as per AJCC's 8th edition new guidelines, prognostic stage includes TNM stage, which is anatomical based, along with the tumor grade, ERPR status, and multi-gene panel outcome, which showcases that whether the patient has low risk or high risk for recurrence. So what they are trying to say that is prognostic staging customizes patient's prognosis, aiding in effective treatment. Now, are all patients equal? Can patients utilize the tests that have been developed in the West and on all patients, or do we need to have different tests for different patients? So the answer to this lies in looking at the way Asian breast cancer patients and Western breast cancer patients come down with the disease. As you can see on slide 6, Asian patients tend to be younger. At age of onset, the mean age is about 46 to 48 years. They have a higher tumor burden at diagnosis, primarily with one node positive disease, and they are typically symptomatic at detection, that is stage 2. And as against the Western patients who are older compared to the younger, to the Asian patients, the disease is primarily in 50 plus 60 disease, 50 plus age. They have smaller tumors, they're primarily screen detected, and they are typically node negative. And because of these clinical parameters, and the biology of the disease also differs, and hence the unmet need we felt was to develop a test that is developed and validated to on Asian patients. Now, what is CanAssist Breast? CanAssist Breast is one of those tests which is a prognostic test developed on Asian patients. It uses immunohistochemistry as a platform, as against real-time PCR or microarray based test in the West. We perform immunohistochemistry for 5 biomarkers, which I will get to in my next slide. And those slides are graded quantitatively by oncopathologists, and that input, along with the morphometric analysis of the tumor, specifically tumor size, tumor grade, and node status of that particular patient's tumor, is taken as an input for our state-of-the-art artificial intelligence-based machine learning algorithm, which gives us a risk score. And that risk score we call CanAssist Breast risk score, which is a number between 0 and 100. If the risk score is 15.5 or less, we call the patient low risk for cancer recurrence. And if the risk score is 15.6 or higher, the patient is classified as high risk for cancer recurrence, and the treatment can be planned based on this. CanAssist Breast is developed using a training set of 298 patients. 95% of the patients are Asian. Now, what are the 5 biomarkers? We often get these questions, and we really, I would like to stress here that we go beyond proliferation and hormonal indices, which are typically what is considered most important in early stage ER-positive breast cancer. However, we look at these 5 biomarkers, CD44, 2 cadherins, and 2 AVC transporter proteins. Why these 5 biomarkers? Because we really looked at the biology of the tumor. We believe that the cancer begins in the duct, and then the cells of tumor actually go through many processes, many signaling events to really go out of the tumor in the breast, and then lodge, go into the blood vessels, and then lodge themselves somewhere in the liver, lung, bone, and form another tumor. And we looked at in depth what are these steps that are critical, and we realized that EMT, cell loss of cell adhesion, MET, mesenchymal to epithelial transition, and developing chemoresistance leads to distant metastasis. And these are the 5 key biomarkers representative of these multiple steps in which are considered in CanAssist Breast IHC protocol. Now, CanAssist Breast has undergone development and rigorous validation over the last 9 years. We started the work in 2011, and we have started selling from 2016. What are the methodologies we use? Every test must show analytical validity, clinical validity, and then use it in clinic in terms of clinical utility. With respect to analytical validity, we have shown for immunohistochemistry based test that it is reproducible and repeatable by doing analysis on various parameters listed here. Clinical validity is showcasing that the test has high NPV, high negative predictive value in patients other than whom it was developed on, and we have showcased this on close to now 2,000 patients from India, US, Spain, and a few more studies are ongoing in Germany, Austria, and Italy. And clinical utility is prospectively used, how the test is being used prospectively in patients in a day-to-day setting today. And we have so far sold more than 850 tests in India, Sri Lanka, and Bangladesh. Coming to analytical validation, in the interest of time, I won't go through those details, but as per EGAP, for immunohistochemistry based tests like CanAssist Breast, we ensure that repeatability and reproducibility are showcased very conclusively, and by doing intra-run, inter-operator, intra-pathologist, and the same parameters within the run, within pathologist's opinion, etc. And all of these things have showcased that the intra-class correlation coefficients of IHC gradings is very high. The two pathologies will give the low risk stratification. The risk scores may differ, but the category does not change, indicating the test is robust. Now moving on to clinical validation. Global clinical validation, which I'm going to present today, showcases the various studies we have performed in India, in Europe, in Spain, and in Austria, and also in the US in multiple centers. Now coming to the cohort details. So today I'm going to present data on a cohort of 1385 patients. Out of that, 871 patients are Indian and the rest are Caucasian, 514. So I wanted to first highlight the differences between the cohorts that we see. And for example, as I mentioned, Indian cohort has more under 50 patients compared to the Caucasian cohort. The Caucasian cohorts have more over 50 patients. In terms of tumor size, I remember I mentioned we have a higher tumor burden, T2 tumors, and with respect to node status, we have less node negative compared to the Caucasians, and we have more node positive patients compared to the Caucasian day patients. And importantly, grade, we have higher grade 2, grade 3 disease burden compared to West. And in terms of therapy, the treatment that has been given to the patients in the past, we have about 80% patients treated with chemotherapy, whereas in the West, about 50% patients do not receive chemotherapy, indicating the differences in the treatment based on the disease at presentation is different. Now, we were just curious, considering all the clinical parameters etc. different that are there and different between the Indian and Caucasian cohort, how does CanAssist Breast segregate these patients? As you can see, CanAssist Breast is able to segregate patients. This is the total cohort of Indian and Caucasian patients, and treated and untreated with chemotherapy. CanAssist Breast is able to showcase low risk, low risk from high risk very well in the Indian cohort as well as in the Caucasian cohort. So despite all the differences, CanAssist Breast works efficiently with a very high NPV in both the tests, in both the populations. Now, clinicians often ask us, how about in clinically low risk patients? That is, those are typically considered to be, those are typically have been treated without chemotherapy and endocrine therapy alone. So this cohort is entirely in endocrine therapy alone cohort, primarily consists of T1, T2, N0s. So as you can see here, CanAssist Breast is able to segregate the low risk from high risk in a statistically highly significant manner. In total cohort, in T1 N0 cohort as well as T1 T2 N0 cohort, showcasing that CanAssist Breast can work very well even in patients who are considered clinically low risk. There is a population of about 11% patients in the T1 N0 who are high risk, and in T1 T2 there were at least about 14% patients missed out. So were considered as clinically low risk, but actually they would have benefited from taking chemotherapy since they are recurring. Now, what about the age of the patient? So we've showcased that CanAssist Breast works well in under 50 as well as over 50 age of patients equally well with a very high significant p-value. Same was the case in node negative and node positive cohort. CanAssist Breast is able to segregate patients in low and high risk very well, with a very significant risk stratification. And finally, coming to chemotherapy benefit aspect of the test, we have showcased that if you look at the Kaplan-Meier analysis of all of the patients classified as low risk for cancer recurrence by CanAssist Breast, they are all, whether the patients receive chemotherapy or they receive only endocrine therapy, the graphs are overlapping, indicating there is no added benefit of chemotherapy to these patients. Whereas if you look at all the patients stratified as high risk for cancer recurrence by CanAssist Breast, the patients who did not get chemotherapy, despite being classified as high risk, actually did worse and had many more recurrences compared to patients who got chemotherapy, and their survival was better. This is metastasis-free survival was certainly higher than the patients who did not get chemotherapy. So this shows that only high risk patients are getting benefit of chemotherapy. CanAssist Breast, we have also done a multivariate analysis to understand which is the most important predictor of prognosis, and compare age, tumor size, node, grade, stage of the disease, and treatment, whether chemotherapy was given or not. Amongst all these parameters tested, we found that CanAssist Breast risk score is the only important has a high hazard ratio with a high p-value, indicating it is the only important independent predictor of prognosis compared to all the parameters we have checked. Moving on to why is this risk stratification even important? So this is to showcase that yes, when the patients are stratified as low risk for cancer recurrence or high risk for cancer recurrence, the patients stratified as high risk for cancer can actually get added therapies. And thanks to Stephen Johnson's work, which was talked about in ESMO as well as published in JCO recently, he's abemaciclib, a CDK4/6 inhibitor. He was shown to be extremely beneficial in clinically high risk patients, and this was done without any use of any prognostic test. So they have showcased that there is a 25% increase in invasive disease-free survival if CDK4/6 inhibitors were given to clinically high-risk patients. So what we are suggesting it is, instead of giving it them to all clinically high-risk patients, which were used in this trial, that is T higher, more than 5 centimeters, grade 3, high Q67, please do CanAssist based on all of these clinically high-risk patients first. Understand the high-risk patients, which is only 56% of this population, and give CDK4/6 inhibitors only to the CanAssist-based high-risk patients, which are part of the clinically high-risk patients, and spare the rest of the 92 low-risk percentage patients. Because even in the Monarchy trial, they have showcased that the patients who benefited from CDK4/6 inhibitor had an improved survival of 92.2%, indicating not all patients benefit, but the high-risk patients certainly benefit from getting CDK4/6 inhibitor. Moving on to the head-to-head comparison of CanAssist based with Oncotype and MammaPrint. The take-home message from this slide is we looked at head-to-head comparison on close to 110 patients, and showcased that while Oncotype calls 62% patients as low risk, CanAssist called 84% patients as low risk, and Oncotype also called intermediate plus high risk together 18%, CanAssist called 16%. What we found that what we later looked at is what is the concordance between these two tests, and we see that there's 82% concordance on the low risk stratification by both the tests. If I'm sure you all remember the Optima prelim trial in which Oncotype was compared with MammaPrint and 4 other tests, and the overall concordance in the low risk was not more than 40 to 60% amongst the Optima prelim trial. So this is a very high concordance, first time ever shown of Oncotype with any other test. And this data has always been published and also presented at ASCO. Certification of Oncotype intermediate risk zone was also looked at, because that is often an issue for planning treatment. And we see that 85% of the intermediate risk category patients were classified as low risk by CanAssist Breast, and that is exactly what is shown by the TAILORx trial as well. And so this is finally to showcase that CanAssist Breast risk stratification compared to the TAILORx cutoff, 0 to 25 low risk is 83%, whereas CanAssist Breast does 80. CAB low risk, 83% concordance was observed in CanAssist based low risk, also in TAILORx as per the TAILORx cutoff. Moving on to comparison of CanAssist based with MammaPrint. As you can see, MammaPrint and CanAssist Breast looked at the same same patients, and 67% were called as low risk by CanAssist Breast, 55% by MammaPrint. More importantly, there was 85% concordance between the two tests in the low risk categories, indicating CanAssist Breast can work equally well. Moving on to comparison of CanAssist Breast with other clinically and other parameters which are used typically in the lab, which is Ki67, luminal subtypes, and IHC4. Compared to Ki67, whether you use 14 cutoff or 20 cutoff, the difference in the DMFS was very little, and it was it was not statistically, it was very little and not statistically significant, whereas CanAssist Breast was able to segregate the same 877 patients in two distinct categories with a big difference in the survival. We also looked at CanAssist Breast restratification of low Ki67 and high Ki67. In each of these populations, we were able to carve out high risk patients out of the low risk Ki67 group and low risk patients out of the high risk Ki67 based stratification, indicating CanAssist Breast is more efficient. Finally, moving on to luminal AV subtypes, the total cohort is 972, as per luminal AB classification, only 31% patients were classified as low risk for cancer recurrence, whereas as per CanAssist Breast, 95%, 75% patients were classified as low risk for cancer recurrence with equally good distant metastasis-free survival with luminal A's. And we further did the restratification of the luminal A's and luminal B's to showcase that yes, there are high risk patients in luminal A, and there are low risk patients in luminal B who can be spared of chemotherapy. And finally, the IHC4 comparison, which is ERPR HER2 Ki67 used in an equation developed by Cambridge. IHC4 based risk stratification does low, intermediate, and high risk. And in our cohort, it was found to be 39%, 35%, and 26% segregation, whereas CanAssist Breast was able to segregate the same cohort of 778 patients into low and high risk distinctly well with a highly significant p-value. We also looked at the intermediate risk group of IHC4 patients, which were also subclassified into low and high risk by CanAssist Breast once again. Now, moving on to finally, how does CanAssist Breast impact treatment? So far, as I mentioned, we have been selling CanAssist Breast in India and near India markets such as Bangladesh and Sri Lanka. And the test has been used by more than 300 clinicians in various cities in India and in cities in Bangladesh and Sri Lanka. And about 67% patients have been stratified as low risk for cancer recurrence who have indeed achieved treatment without chemotherapy and have benefited by using CanAssist Breast. We look forward to serving to the Asian patients and Central Asian patients and Middle Eastern patients as soon as possible, and would be happy to work with all of you on that. So finally, to summarize, CanAssist Breast is a robust, cost-effective IHC-based prognostic test. It is stratification is independent of cohort-specific differences. Chemotherapy benefit is showcased only in high-risk patients. Comparison with CanAssist Breast is extremely good. With Oncotype DX and MammaPrint is very good. CAB is able to segregate patients more accurately than the commonly used parameters such as PCCS and luminal AB based method. High risk CanAssist Breast patients can be given CDK4/6 as an effective way to curtail the risk of recurrence further. And early data showed that 70% patients are benefiting from CanAssist Breast by avoiding chemotherapy. And finally, why CanAssist Breast? It is a made in Asia test, the only breast cancer prognostic test developed and validated on Asian patients. We have all the regulatory approvals. It is patent protected, and data is published in multiple papers listed here. Thank you all for listening, and happy to take questions.